So to give a basic idea about, I think from community medicine and all, you must have learned, I'm just telling these things for junior students. Sri Lanka healthcare system, it's a very big topic in community medicine. But I will just give an introduction, because when it comes to cardiac disorders handling, we'll have to know what our scope is, right? Now, you may have seen when you are very young, you go to the doctor. In that hospital, there is only one doctor or two doctors. That is called dispensary, right? Or a peripheral unit, right? So there are peripheral units. So some children with heart diseases might come to peripheral units. Right? So that is one of the basic units in health system in Sri Lanka. And then there is something called district hospital. Right? You can take a piece of paper. You might write whatever that we feel as important, right? I'm not telling basic definitions of these hospitals, because that is not the scope of my field, right? So that is community medicine. So children might come to peripheral units where only one doctor or two doctors are there. And there is another unit called district hospital. There are little more doctors, like 5-6 doctors will be there. Their handling of children with heart diseases will be different. And there is another unit called base hospital, right? In base hospitals, the facilities are a little less, but better than district hospitals. Right? Some base hospitals will have X-ray machines, right? But they will not have echo machines, like cardiac echo machines. Echo machines will not be there. So base hospital, the management level, the scope will be different. And then you have general hospitals or teaching hospitals. There you have everything, right? You have everything. So depending on where you work, whether you work in a peripheral hospital or dispensary, whether you work in a district hospital, whether you work in a base hospital or teaching hospital, the management of heart diseases, the extent would vary, right? Extent would vary. Now, when you become a house officer, in which hospitals are you going to work? Shania, what do you think? Right? Which hospital are you thinking of working when you become a house officer? Who is a house officer? He's the most junior doctor. That's your first appointment, right? So house officers will be appointed to work in base hospitals or above. Base hospitals or above. Very good. Somebody has very correctly called base hospital and above, right? So it could be a base hospital, right? Base hospital, and then you have general hospitals and then teaching hospitals, right? So if you are a house officer, you have the luxury of working in a base hospital or above. Base hospital or above. Why is that? Why house officers are sent to base hospitals or above? Any reason? Yeah, house officer period is very good. Its house officer period is a training period. You have to work under a consultant. So consultants are there only in base hospitals and above, right? So that makes sense. Right? So there will be a consultant, and then you will be working with him or her, right? And then once your 1 year period is over, internship is over, you will become who? You will become a post-intern doctor. After internship, you will be getting the full registration at SLMC. Then you will become a fully registered doctor, right? When you become a fully registered doctor, you will be called as a MO, medical officer. And then, or you will become a senior house officer. It's the same, right? It's the same, senior house officer or MO. When you become a senior house officer or MO, where will you work? Where will you work? Any idea? Very good. Anywhere, right? Anywhere means starting from peripheral unit, dispensary, and then district hospitals, a base hospital, teaching hospital, anything, right? So depending on where you work, right, different different ways will be there for a child to present when it comes to heart diseases. Right. Suppose you are working as a house officer at a base, right? At a base hospital. Now, when do you think, okay, and a child comes to OPD. OPD is outpatient department, right? When do you suspect, okay, this patient probably is having a heart disease? Yes, mother will not come and say that my child is having a heart disease. So how do you suspect that it's a heart disease? Yes, Amudi, how do you think, okay, this child probably is having a heart disease? Any comments, Kuda? Yeah? When do you suspect, okay, it's probably the child probably is having a heart disease? Yes. Now you might get the smell or the taste of a heart disease in different ways. Either the mother or child will complain, right? Either mother or child will say something suggestive of a heart disease. What is that called? That is called history, right? So this session will be equally important for Viva students and theory students, but mainly for young or junior students, right? So history, right? So mother will say something or child will say something, and then that might alarm us to say, okay, this could be a heart disease. Right? What is the other way, Patum? Right? History is one. What is the other way? Examination, right? When you examine, you might find, okay, it's a heart disease. Now remember, you all are going to become doctors, right? So suppose you are now say 25 years. At 25 years, you will become a doctor, right? And you will retire at 63 years of age. Right? Retire at 63 years of age. So 63 minus 25 is say 38. So during that 38 years, you will only do two things. What are those two things? Examination, history taking, examination, history taking, examination. Those are the two things that you would do, right? So history taking, there will be particular complaints that might ring us, okay, this is a heart disease, right? And then examination again will tell us, okay, it's a heart disease. History taking or patient information will keep aside. Then examination. Where will you examine to say what examination will tell us, okay, this is a heart disease? Yes, Vinuri, where do you want to examine to say that it's a heart disease? Yes, heart disease. You might find that the child is having a heart disease by examining the chest. But before that, by just looking at child generally, you might think, okay, this could be a heart disease. And remember, medicine is so beautiful if you start to learn it in a practical way. So this child is coming, we'll have an imaginary child, a 4-year-old child is coming to base hospital, Kawasaki, that is where I work, right? A 4-year-old child, suppose you are seated, right? You are seated as a medical officer at OPD, right? Now this child is coming. You would take history from the mother, right? And you will examine. Out of two, what do you do first? History taking or examination? Kevin Amara Sekar or Amara Singha? Do you take the history first or examine first? Yes. History taking or examination? Yes. Yes. Many of us have commented that it's history taking. I would say no. No, right? It's not the history taking that we do first, but examine. We don't do a proper examination, but we will just look at the child, right? You look at the child is what, Kuda? Observation. That is where examination starts. That is where examination starts. You will look at the child and you will ask child to sit down. If child can sit down, if the child is not too ill, you will give a seat to the mother as well. Then you will start having a chat, right? Then you will start having a chat. Yes, very correct, Pulasti. And in case of emergency, you might not take history. You will rush to the child straight away and examine, right? So it depends on the condition, and however, even if the child is not ill, you will just look at the child, Looking at the child itself is examination. That is where interview begins. Am I correct, Charita? Right? So that is where we start. Right? When you look at a child, how do you say, this is a heart disease? You are looking at the child, and by looking at a child, how do you say, this is a heart patient? How do you say? Yes, yes, you will just look at the child. When you look at the child, there may be few features to say that it's a heart disease. If I ask this question, what is the commonest finding when you look at a child when he has a heart disease? What is the commonest feature that you will observe as a doctor when child has a heart disease? Yes. Commonest. There will be several features, but I'm asking what? Commonest. Yes. Any comments? Right. Ulasti, you kept answering very well. What is the answer for this question? Yes, the commonest feature is what? Nothing. Nothing, which means what? Most of the children with heart diseases will not have anything obvious to see, right? Children might have a hole in the heart, right? But they will appear as you and me, right? Children might have serious deadly conditions, but they might appear as you and me. So what is that? Asymptomatic, asymptomatic. Right? No symptoms at all, but child will come, and then when you examine, you might find that child has a heart disease. Right? Remember, just because child has a heart disease doesn't mean that he is having some external manifestations. Most of the children with heart disease will look normal. That is why it's very important to examine the heart in any child. Right? In any child. Right. Now, asymptomatic children, normal looking children, who will pick them up? Who will pick them up? Is that the consultant who will pick those children up in the clinic, or who? Yes, normal looking children can be picked up as having heart diseases if you actively examine for a murmur. Who does that? That is commonly done by medical officers during school medical inspection. Have you heard of that, Kuda? School medical inspection, every child will get a chance to get their heart tested with the stethoscope. Then the very good medical officers will find out a funny sound or murmur, and then they will refer the child to pediatrician. Right? So one of the commonest way how a child with heart diseases would present to a doctor is asymptomatic, and they could be picked up by auscultating the heart. Asymptomatic is one of the commonest ways. Right? Asymptomatic is one of the commonest ways. Then what are the other ways? There are some appearances which make us to suspect this child might have a heart disease. Those are called what? Syndromes, right? Syndromes. What are the syndromes which might tell us, Krishan, look at this child, he might have a heart disease. What are those? Yes, what are the syndromes? What syndromes? Like Down syndrome, we must have heard, right? Down syndrome. So Down syndrome, children might have heart diseases. So it's a must to auscultate any child with Down syndrome. So some syndromic children might be picked up. Non-syndromic children like you may be picked up as having a heart disease if somebody auscultates, right? So they are asymptomatic. So asymptomatic children may be picked up. Syndromic children will be picked up as having heart diseases, right? And then you will start to have abnormalities on appearance. Right? What are the features? What are the common features to tell us this child probably is having heart disease? Yes. What are the common features to say this child probably? Please mute your mics, otherwise we might hear your private conversations internationally, right? I don't think that you would like that, right? Okay, right. Host muted everyone, including me, right? Right. Okay, so So what are the features to say that it's a heart disease? When you see a child, we can remember, if you see 100 children with heart diseases, 90 will appear normal. So remaining 10 will have some funny looks. What are those? There are some children who are edematous. They are swollen, right? They are swollen. If you go to the note, Pudha, just for a minute, right? So this is where we are. I don't know. Imani, can you see that I'm sharing a note? Yes, wonderful. Right. So how do they come to a doctor? Right? How do they come to a doctor is the question. Right? How do they come? We can remember, right? We can remember the commonest one is what? Asymptomatic. Right? Asymptomatic. Asymptomatic is the commonest, which means they don't have any symptom. Right? You might write this while I'm going on, or I will send you the edited document. Right? So that's either way is possible. Right? So asymptomatic. And then how do you pick up asymptomatic children? So during SMI, school medical inspection, you might find a murmur, right? Murmur. Right. There may be children with murmurs who you might pick them up during school medical inspection. So that's possible. And some children will have what? DIB, difficulty in breathing, right? Difficulty in breathing. And someone tell you, Buddha, why children with heart disease can have difficulty in breathing? What the pathophysiology of it? Yes, what's the pathophysiology? I'm sure at least 100 students from this gang have followed our pathophysiology course that we have done a year ago. Yes. What's the pathophysiology? Now remember, you are going to become a doctor. When you become a doctor, you have to pass 2 exams, theory exam and clinical exam, Viva exam. In Viva, they will test what? Whether we know the mechanisms of diseases, pathophysiology. Remember, now in your Viva exam, right? If an examiner comes and asks, tell me why heart disease children have breathlessness. Tell me why heart disease patients will have breathlessness. Yes. Any comments? What are the reasons? Why do they get that? Right? The reason is this, right? Reason is this. Where's this one? Right, please give me a second. No. Right, okay. Yeah, am I? Right. Okay, so I think you can see this diagram. So this is the heart, right? We can remember this is the heart, and then these are 2 lungs. It will be nice if you can also draw with me, Buddha, then it will be interactive and you will remember things. And it's so passive, right? Okay, so now when you have a heart problem, what could happen? There could be heart failure, right? There could be heart failure. What do you mean by heart failure? In this condition, right, heart failure could be an emergency. This could be a very good Viva topic and theory topic, right? Now, when you have heart failure, what happens? Heart does not pump enough blood out. Heart does not pump enough blood out. Suppose the heart is having 100 ml of blood, right? 100 ml of blood. During contraction, right? During contraction, heart is supposed to pump around 70 ml out. So out of 100, you are supposed to pump 70 ml. Right? But when you have heart failure, instead of 100, you might pump, say, 50. Sorry, instead of 70, you might pump only 50 ml out. Right? You are not pumping 70. Instead, you are only sending 50 out. Then what happens? There will be 20 ml more remaining. Right? 20 ml more remaining. Did we understand that? We are supposed to pump 70, but you are only pumping 50. So there will be 50 ml in total remaining, right? So what is happening? In the left ventricle, right, there is accumulation of blood. Am I correct? Accumulation of blood because it does not go out. When it does not go out, what will happen? You can't take next cycle of blood, right? So this blood does not come in because the ventricle is already full. When ventricle is already full, what happens? Blood can't come this way enough. Am I correct? Blood can't come this way enough. When blood does not have the ability, the chance of coming into the heart, what will happen? That extra blood will remain in the lung, isn't it? Extra blood will remain in the lung. So there will be extra 20 remaining in the blood, lung. If that happens over and over again, what will happen? At one fine time, lung will be fully wet. Lung will be fully wet. Lung will be all having filled with water, or blood rather, blood. So when the lung is wet, what will happen? Oxygen cannot come, right? Oxygen will not dissolve enough. Oxygen will not dissolve enough. So the lungs do not have enough room to accommodate air. Instead, it is filled with water. It is like you are drowned. Right? When you drown, you find it difficult to breathe. It's the same when the lungs are wet. Lungs will get wet when you have heart failure or heart disease. When these lungs are wet, the nice medical term to use that condition is known as what, Puda? Pulmonary edema. Pulmonary edema. So when you have heart disease, you will get pulmonary edema. Right? You will get pulmonary edema. So when you have pulmonary edema, what happens? Your lungs are fully loaded with water. So what happens? You find it very difficult to breathe. You find it very difficult to breathe. So child will come with breathlessness. He does not have enough oxygen. Right? He does not have enough oxygen. If you do not know this pathophysiology, trying to manage a heart disease patient as a doctor is just a joke. Right? If you do not know what is happening inside the heart, how are you going to fix the problem? It is like, I don't know what is happening inside my car, but I try to fix it when it is broken. Right? Without knowing pathophysiology, becoming a doctor is just a dream. Right? So this is easy. So see, this is nothing. So children with heart diseases will get heart failure. Because of heart failure, they can have wet lungs. So that is called pulmonary edema. Pulmonary edema will make them to be breathless. Pulmonary edema will make them to be breathless. So if you see a child who is breathless coming to the hospital, one of the first few things to remember as doctor is what? Has he got a heart disease? Isn't it? Has he got a heart disease? What are other reasons? Has he got a lung disease as well? There are several reasons, but one of the commonest things is what? Has he got a heart disease? When you have heart disease, lungs will say, now what is happening? Please give me a second. Hello? Hello? Right. Please give me a second. Right. Okay. Right. Dr. Lagat is having class on coming Monday. Right. Coming Monday. Please give me a second. Yeah, coming Monday. What time is this? It's at, yeah, I will let you know time. Right, okay, I will give you information soon. Okay, what is, yeah, coming Monday, 7 p.m. to 9 p.m., right? Dr. Lagat will have an open session on coming Monday, 7 p.m. to 9 p.m. Right, okay, please join that. Right, okay, so when you get a child with difficulty in breathing, right, difficulty in breathing, you might think, is it a heart disease? When you have heart disease, who is going to suffer as an organ? One of the organs is lungs. Lungs will say, now look, Krishan, right, we don't have anywhere to go. Heart is full. Heart is full, right? We can't go anywhere. We are so dependent. We are breathless. Who else will suffer? Who else will suffer? Everybody will suffer. Who is the other one? Look at this now, please, Buddha. So this is what? This is called superior vena cava. Superior vena cava. And what is this? This is inferior vena cava, right? Superior vena cava and inferior vena cava. Now, when the lungs, the heart is not functioning properly, left heart will be full. Also what? Right heart also will be full. This heart also, this side also will be full. Then the head and neck will say, right? Today there is huge traffic. Nothing can go down here. Nothing can go down here. So what will happen? You can't send blood from head and neck down. So what will happen? You will get facial swelling, isn't it? Facial swelling. You may have seen people with heart failure. They have swollen face. They have swollen face. What else? The lower limbs also will tell the upper limbs, the head and neck. Now, Machang, it's not you, right? We are also getting problems, right? Even we can't send blood up. What is happening, right? So what happens? All blood will be remaining in the lower limbs as well. Then you will get what? Feet edema, right? There will be edema of lower limbs, edema of the face, right? And then what? Very young children, infants will say what? Infants will say, our problem is we can't get up, right? We can't get up. So we can't, now infants can't get up. So this is me, right? So this is my head, right? I don't know whether you can see me. So this is my head. So when you have a heart disease, what happens? There will be difficulty in sending blood down. So my head or the face will swell. Else, my legs also will be swelling. Right? Will be swollen. But infants, what happens to them? Infants, they can't get up. Small babies, they will be like this. Right? Where is going to swell in them? What? Their buttocks. Right? Their buttocks. Because that is the dependent area. That is called what? Sacral edema. Sacral edema. So children with heart disease can present with edema. What edema? Facial edema, lower limb edema, and then sometimes sacral edema. Infants, small babies might have sacral edema as well. So that's the pathophysiology, right? That's the pathophysiology of heart failure and children having heart diseases. So we can remember, so this is where we were difficulty in breathing. This is due to what? This is due to pulmonary edema, right? Edema. So you will get pulmonary edema, right? And then what is the other manifestation of heart failure? They will be edematous. They will be swollen like this, right? They will be swollen like this. So there will be swelling, right? Edema. Where will get swollen? Facial, right? Facial, and then lower limb, right? Or ankle. The better word is ankle. Yeah, else sacrum, sacral, right? Sacral edema, all those are possible, right? So they could present with edema, right? What else? What do you see here? What do you see here? Look at this, Buddha. So what do you see here? Now this child, you can see he is having bluish discoloration around the face, bluish discoloration around the face. And the second child, you can see that his tongue is blue. Also where the lips are blue as well. So that is called what? Cyanosis, right? So this is called cyanosis, right? Have you seen children with cyanosis? Yes or not, right? In real, we have enough and more children with cyanosis at coming to premier clinics, right? Premier pediatrics clinics. When you come to premier hospital, premier healthcare, you will start to see these children in real, right? So this is called cyanosis. Now cyanosis could occur in different parts. Lips could be cyanosed. That is called what? Peripheral cyanosis. Peripheral cyanosis. Lip cyanosis is peripheral. You can write to the lip cyanosis, peripheral. What else? Where else could be cyanosed? The tongue could be cyanosed. So that is called what? Central cyanosis, right? Children can present with central cyanosis and peripheral cyanosis both, right? Central cyanosis and peripheral cyanosis both, right? Now, what are the other ways that a child with heart disease would present? Still, remember, we did not even touch the child. We did not even touch the child. What did we see? We saw an asymptomatic child. Oh, the school medical inspector has seen a murmur. We have not auscultated yet. Still, child is just next to our consultation table. He's just away, right? Right? So you are not seeing the child very closely, right? So what's happening? The child is far away. You are looking at a breathless child, or you see an edematous child, or you might see a cyanosed child. Remember, if you remember this session, you don't have to remember anything regarding pediatrics, children examination related to heart disease. This is all about this. Right? This is all about heart examination in children. Right. Now what? You might see this type of a chart. What is this called? What is this? What do you see this? What do you see? Is this Avartitavagu? What is this? Right. What do you see this? What do you see here? It's called a fever chart. It's a fever chart. Right? This is a fever chart. Fever chart. Or temperature chart. Now, can children with heart diseases present with fever? Yes or no? Yes or no? Yes. In which conditions do you get fever and heart problems? Remember, when you get a middle ear infection, when a bug goes to middle ear, you will get fever. When bug goes to throat, you will get fever. Like that, bugs can go into the heart. Right? So that is called infective endocarditis, right? Infective endocarditis. That's one reason why a child could present with a heart problem and fever. Infective endocarditis. What is the second one? You must have heard this before. Rheumatic fever. Rheumatic fever. Rheumatic fever. So that also can cause fever and heart problems. We'll see what those heart problems are. But remember, when a child comes with fever, one of the very important things to exclude is it a heart fever? Is it a cardiac fever? Because heart is another organ which could be infected. There's another condition where a child might have a heart problem plus fever. Can you remember, Buddha? A senior student might remember. Juniors might not have heard of that. Very good. Kawasaki disease. Kawasaki, right? You may have heard of a disease called Kawasaki disease, right? So what are the three reasons why a child could present with fever and a heart problem? Heart fever, cardiac fever, three reasons. Infective endocarditis, rheumatic fever, and Kawasaki, right? Kawasaki. We'll see what they are a little later, right? What they are a little later. So what did we see by now? A breathless child, or asymptomatic child, or cyanosed child, or edematous child, or a feverish child. Right. Now suppose this child is having fever. Right? There are few reasons why a child could have fever and heart problem. Now Buddha, look at this. What is this? Yes, what is this? Now these are the manifestations of rheumatic fever. Rheumatic fever. So this is what? Now this is called Erythema Marginatum. What is the name? This round rash is known as Erythema Marginatum, right? Erythema Marginatum. I don't know whether I can insert a text box. Yeah, so this is Erythema Marginatum. Right. So this is one of the rashes you would get related to rheumatic fever, right? Rheumatic fever can cause something called erythema marginatum. And then you can see few nodules just under the skin. So these are called subcutaneous nodules, right? And this child, the third child, you can see that he can't maintain the norm, maintain one posture. He is dancing this way and that way, right? So this is called chorea. Sydenham's chorea. Forget about Sydenham's chorea. It's chorea. Chorea are uncontrollable involuntary movements like that. He will be just jittery and fidgety. So like this. So chorea, if a child presents with chorea, dancing type movements, you might have to think, is it something to do with the heart? Or if a child presents with subcutaneous nodules, you might think whether it is something to do with the heart. And then erythema marginatum. And there are two other associated conditions that you might get in case of rheumatic fever, right? So we don't have pictures of them, but what are the other two associations? They can have arthritis. And then last one, carditis. That is why it is relevant to today's topic. When you have rheumatic fever, there are 5 features to that. So you don't have to remember these again in your theory course, because we are getting some understanding by now itself. So if somebody asks, what are the 5 features of rheumatic fever? Remember, Buddha, look at this, right? So when you know these 5 features, you are done. What are those? Carditis, arthritis, erythema marginatum, subcutaneous nodules, and chorea. Right? Remember. So those 5 features, if you have those, you know that it's a child has got rheumatic fever. Right. Why is it relevant? Because that is something to do with the heart. So when you are in the OPD as MO at whatever hospital, if you see this type of rash, check the heart. If you see these kinds of nodules, right? So when you see these nodules, don't say, this is rheumatic fever, right? So this is rheumatic fever. So remember, these are not mosquito bites, right? These are not mosquito bites. When you see this, you might examine the heart. That is when you show that you are a smart doctor, right? And then if you see a child with coriform movements, check the heart. If you see a child with arthritis, check the heart. If you see carditis, of course, you will do the full cardiac examination, right? So if a child comes with any of those features, think, is it the heart? Suspect about the heart with a very low threshold, so that you will never miss a heart disease and child will never die of undiagnosed heart disease. Right? Now what is this? Right? So this is another way how a child with heart disease could present, right? So what are these? Now, these are called Osler's nodes, right? Osler's nodes. You can see painful nodules, Osler's nodes, right? So these are not words, right? These are not words. I have seen children who were reassured by some of the doctors and told me, word, this is a subcutaneous nodule, this is not a word. Right? And then you can see something called Janeway lesions. And then you can see funny shaped fingers, right? Fingers, this is called finger clubbing, right? Fingers are swollen and there is some bumpy appearance on the nails. So this is called finger clubbing. And then you can see some small hemorrhages just under the nail bed. What is this, Buddha? This is called sphincter hemorrhages. So if you see those, you know that you are dealing with a particular heart problem. And then if you are skilled enough, you will examine the eye. There's a specific way how you would examine the eye. That is called fundoscopic ophthalmoscopic examination, right? Ophthalmoscopic examination. So there you will check something called rod spots, right? Those who are practicing as pre-interns these days at my ward must have seen how to do ophthalmological examination, right? There's a group of students who have come and working with me. So they are working as house officers. They do everything. Today they saw a lady with ectopic pregnancy, facial nerve palsy, and then bronchial breathing and pneumonia and cerebral palsy, you name. They saw also, you will also get a chance to come and see those patients. Plus, we have the patient library at Premier as well. So when you come there, you will see sphincter hemorrhages and rod spots. Checking these, getting our eyes familiar to these pictures just by looking at Google or textbook is the old style. That's the old style of learning. Now we don't learn in that way. We see real patients at Premier and the other places. When you say, I have seen where? Google or textbook is the out of fashion. So you will start to see all this, right? Anyway, if you see Osler knots, chain lesions, and then clubbing, sphincter hemorrhages, and rot spots, if you see everything together, this is called Vatkuda. This is called infective endocarditis. What is the name? Infective endocarditis, right? So infective endocarditis, these are the manifestations, right? So this is nothing difficult. It's very easy. Even if you're a pre-departure student, you will start to understand, right? So you must have remembered much complex, much complicated things like than this, isn't it, Imani? Right? When you are a biology student, your biology teacher must have told 50 features of Annelida, 30 features of mollusca. Did you remember all those? Yes, that is why you became a doctor today, medical student today. Now compared to your teachers, I'm much better because I'm only asking to remember 5 features. What are those? 5 features of infective endocarditis, not 30 features of Annelida. Osler's nodes, genuine lesions, clubbing, sphincter hemorrhages, and rot spots. If you know that, you are done. What is this? It's infective endocarditis, right? If you're too curious to see what is happening in the heart in this condition, that this is what is happening, right? Heart is infected, right? Heart is infected. You will see the heart like this. Heart like this. You can see these are infected materials. These are known as vegetations. Valves are fully damaged or getting damaged, right? When the valves are damaged, you know that valves will be leaky or they will be not opening properly. So you will hear funny sounds. When the valves are leaky, the flow will be turbulent. Flow will be turbulent. When valves are not opening, flow will be turbulent. You must have remembered when you were learning physics, Bernoulli's law. When the flow is turbulent, you will start to hear start to have different other energies. One of the energies is sound energy, right? So when you have valvular damage, they will start to have murmurs, right? They will start to have murmurs. So this is the terrible look of the heart when you get infective endocarditis. So you can cut open and look at the heart. Instead, you will look at this, right? You will look at this, and then you will auscultate the heart. Then you will hear a murmur, right? Then you will hear a murmur, right? So if you hear a murmur plus fever plus these features, what is the diagnosis? You will say that this is infective endocarditis. Remember, one patient will not have all the features of a full package of infective endocarditis. Instead, he might present with only Osler node and fever. They might present with sphincter hemorrhage and fever. They might present with clubbing and fever. We should be smart enough to pick up that and get an echo done and treat the child. Right? Even if you're a first-year medical student, the smart students will tell the consultant, sir, now this child is having clubbing and fever is going on. I think that it is infective endocarditis. Shall we get an echo done? That's the kind of medical student that is expected by examiners in the exam, and that is expected as house officers in the hospital. Remember, so these are all important. Now look at the next child. Who is this? What is this look? Yes. So what do you see? What do you see in this child? What are the features that you would tell as abnormal? Yeah. Which features are abnormal in this child? Now look at this child's tongue. Right? If you just forget about the mouth and if you just concentrate on tongue, which fruit will come to your mind? Which fruit will come to your mind? Yeah. Yes, very good, very good. So it's like what? Yeah, it's strawberry, right? It's like strawberry, right? Somebody has commented, no, this is Varakaluke. And so who is this? So this is strawberry. So this is called what? Strawberry tongue. What it is? This is called strawberry tongue. And what else do you see in this child? If you look at his eyes, right? If you look at his eyes, you can see that eyes are red, isn't it? Eyes are red. What else, right? So this is the mouth. The lips are also red. Red lips, red eyes, strawberry tongue, and what else do you see? The skin is peeling off. Skin is peeling off. So if you see all these, what is the diagnosis here? Yeah, what is the diagnosis here? This is called Kawasaki disease. What is this? Kawasaki disease. You might get children with Kawasaki disease there, right? Kawasaki disease could appear in Viva, right? Kawasaki disease could appear in Viva. Kawasaki disease. Kawasaki disease could appear in clinical exams. Kawasaki disease is one of the pet topics in theory, and Kawasaki could come in your undergraduate university exam as well. Right? Kawasaki is everywhere. Right? And one. So that is what you do from a distance. Now you are coming closer to child and start to check the child with this magical gadget. What is this? It's the stethoscope. Right? It's the stethoscope. When you check with the stethoscope, you might hear funny sounds. Those are called what? Murmurs, right? Murmurs. So murmurs could be heard when the heart is contracting. When the heart is contracting, you might hear murmurs. Those are called systolic murmurs. Systolic, S-Y-S-T-O-L-I-C, right? S-Y-S-T-O-L-I-C, systolic murmurs, systolic. And some murmurs may be heard when the heart is relaxing, right? When the heart is relaxing, those are called diastolic murmurs. Right? Now, if you can auscultate your own heart, provided you have a normal heart, you will start to hear what? Lub-dub, 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 lub-dub. If you hear anything else than lub-dub, there are some conditions, some children, when you auscultate, you will hear something like this, lub-dub, lub-dub, lub-dub. So what is the sound? That's a murmur. That's a murmur, right? So when you start to come to clinicals, you will start to hear murmurs, right? You will start to hear murmurs. If you hear a murmur in a child, you know that he has got very likely he has got a heart disease, not always, but there may be murmurs. What are the two types of murmurs? Systolic murmurs and diastolic murmurs. Right? Systolic murmurs and diastolic murmurs will be heard. Right. Okay. And then what else? Some children can present with what? Failure to thrive. What is that? They do not gain weight enough. They do not gain weight enough. Mother will say, my child is not putting on weight. He's always very thin-built, skinny, right? Baba, bara වැඩි වෙන්නෙම නෑ doctor, right? ඒක හොඳටම අවුල්. අටු ගහිලා, right? ඇට ගහිලා ඉන්නේ. So failure to thrive, right? Failure to thrive. Remember, when a mother says that the child is having failure to thrive or not enough weight gain, it is not always the diet. That could be something to do with the heart. When you have heart failure, you will be consuming a lot of energy to maintaining the heart. So you will not have anything else, any more energy to put on weight, right? So if a child presents with inadequate weight gain, think about the heart, auscultate the heart, right? Heart auscultation is important in case of failure to thrive as well. Right? And then some children will present with heart failure, right? We can remember the features of heart failure. They will have difficulty in breathing. They will have difficulty in breathing. They also can have edema. Edema, right? Edema will be there, right? And then what? When you auscultate a child with heart failure, we initially came to an understanding that their lungs are full with water. What is the name to that? Pulmonary edema. How do you know that child has got pulmonary edema without cutting open the chest? How do you know that child has got pulmonary edema? Is there a way to find out whether child has got pulmonary edema clinically? They will be breathless. They will be breathless. What else? Yes, they will have funny sounds when you keep the stethoscope on the lung. When you keep the stethoscope on the lung, right? Today, you must be having a stethoscope. Put the stethoscope on your lung. You will hear breath sounds only, breath sounds only. But if you have pulmonary edema, you will hear crepitations, right? Chara chara sound, right? Chara chara sound. These are called crepitations, right? Crepitations. So if you hear crepitations, if the child is edematous and if he's having difficulty in breathing, you know that it's nothing else but heart failure. Nothing else but heart failure. Right. Now, what do we know? We know how a child with heart disease would present. Right? How a child with heart disease would present. If I want to summarize that part, how do they present? They might present commonly asymptomatic. But I remember whether you also can remember what I remember. Right? They will be asymptomatic. They might come with breathlessness, difficulty in breathing. They might come cyanosed, right? They might come with a murmur, right? They might come with a murmur. What else? They can have fever chart. Then what? They can have features of rheumatic fever, Erythema Marginatum, subcutaneous nodules, chorea, arthritis and carditis, that is the murmur. They might come with features of infective endocarditis like rot spots, Osler's nodes, J.N. lesions, splinter hemorrhages, and clubbing, right? And then they might also come with features of Kawasaki like strawberry tongue, red lips, red eyes, and peeling off of the skin. There are several others, but if you can remember these, you are done, right? So if you know Kawasaki, so this is how we learn things, right? So this way I can finish the whole syllabus of pediatrics as a single story, right? We don't have to even look at textbooks as long as we share our experience. It's easy, right? It's easy as long as you start to love this subject, right? So heart failure, how to manage them initially. That's the worry, right? How do you manage a child who is coming with breathlessness as a OPD doctor, right? How to manage, say, heart failure initially at OPD, yes. What is the answer? Yes. Now this child, imagine, right? Imagine, now look at this, look at me, a child coming with edema, he's breathless, right? And you are working at the OPD, mother is too worried, and the child is breathing with greatest difficulty. You auscultate the child, you hear these funny sounds, chara-chara sounds, now you are supposed to do something, right? You are supposed to do something. So what are you going to do here? Yeah, what will you do when the child is breathless? When the child is breathless, yes, what should we do? Yes, when the child is breathless, right? So one of the first things to do is you will keep the child propped up, right? You will have to prop up the child, right? Prop up the child. What do you mean by propped up? You will keep, say, 2-3 pillows, right? And then child's head is little elevated. Child should be kept propped up like this. He will be breathless like this, right? What is he asking for? It's oxygen. Tissues are badly asking for oxygen. So what do you have to do? We'll have to give oxygen as well. So what is the first thing that we do? Prop up, prop up. What is the second thing? Give oxygen, give oxygen. What else? Why is he getting this breathlessness? We can remember pathophysiology. What is the pathophysiology? Child is getting more and more fluid in the lung, right? Child is getting more and more fluid in the lung. So you will have to reduce the amount of fluid, right? You will have to reduce the amount of fluid. So what do you have to do? You will have to restrict the amount of fluid that you give. You will ask the mother, please don't give any more water. We will give. Right? We will give water as much as child needs, but we don't give liberal water. So restrict fluids. Restrict fluids. So you'll have to restrict fluids. What else? Now suppose you have restricted fluids. What does that mean, Buddha? You are no longer giving fluids, but whatever child is already having will remain. Right? You are no longer giving, but whatever child is having inside his body will be there. That is the reason why he has already got breathless. So isn't it a good idea to remove some extra fluids? Yes or not? Yes. Dureksha, what do you think? Dureksha Karyavastha, right? Yes, should be. So you were busy with some other talk. Sorry about that. Right. So anyway, so is it important to remove the extra amount of fluid? Yes or not? Yes. How do you remove extra amount of fluid? You can't put that tube into the lung and remove. So how do you do that? How do you do that? Yes, you can give a drug to increase urine output, urine pill. You can give a drug to increase urine production. So you will lose extra water as urine, right? So those are called diuretics. Right? Diuretics. Today, if you remember one diuretic, that's more than enough. One of the very well-known diuretics is known as furosemide. Furosemide. If you have any of your relatives having heart failure, they may be on clinics, right? Maybe your grandfather, grandmother, if they are on clinic, please ask the clinic book today or tomorrow and check whether this magic drug is there in the clinic book. So that is furosemide. So you prop up the child, give oxygen, restrict fluids, and then you will give diuretics. With that, he will get reasonably better. Reasonably better. But then what do you have to do? You will have to find out as to why he has got this heart failure. As to why he has got this heart failure. This is due to an underlying problem, right? Then we'll have to treat that underlying problem. Detect and treat the underlying problem. Right? So we are talking about children, right? Children. Now, underlying problems which can give rise to heart failure in children are two types. What are those? Congenital. Congenital means the problem is coming from birth. Congenital problems. Right? Or it's acquired. Acquired. Right? Either it's a congenital problem or an acquired heart problem. Acquired heart problem. So congenital heart problems. Can you remember a congenital heart problem in children? Yes, one of the problems is called VSD. VSD is ventricular septal defect. You know ventricles? Left ventricle, right ventricle, right? One koshikawa, dakunu koshikawa. So left ventricle, right ventricle. Between these two ventricles, you have a wall that is called ventricular septum. In the septum, there may be a hole in the heart. If you have a hole in the ventricular septum, that's called ventricular septal defect. There may be a hole in atrial septum as well. That is called atrial septal defect, ASD, VSD. Those are coming from birth. And there's another type of conditions where the heart was normal at birth, but later you are getting this. Right? So what are those? Acquired heart diseases. Example, rheumatic fever. You are not born with rheumatic fever. Then what? Infective endocarditis, J&M lesions and all. Those are acquired heart diseases. Right? So those should be treated. Now, before treating, right? Before treating, we'll have to detect what the problem is. How do you detect what the heart problem is? How do you detect what the heart problem is? We'll have to do some tests, right? We'll have to do some tests. Some heart problems can be detected clinically, even without doing tests, but some others will need tests, right? Some others will need tests. So what are the tests that we do to find out heart problems? Yes, what are the tests that we do to find out heart problems? Yes, how to evaluate, we'll have to investigate. So what are the investigations? One of the investigations that we do is ECG, right? We will do ECG. Right? The second investigation is chest X-ray. Right? We will go through them a little, and then we might do 2D echo, heart scan, echo karana. Right? Echo. Right. Okay. Right. So we will go to all these. Before that, I just want to give a brief introduction because it's 1 to 2 words regarding what is happening at Premier these days, right? Because most of the students, some of the students do not know, some knew, right? Remember, I have started a new concept of Premier Pediatrics clinics. Premier Pediatrics clinics with a faculty of or other external consultants. There are 5 external consultants who have come with me to start this event called Premier Pediatrics Clinics. Right? We have already started clinics. The idea of having these clinics is to give the opportunity for students to see patients. Right? Students to see patients. So you can go to hospitals, but we have made it so simple, right? So you don't have to take any letters from ministry or whatever because Premier is mine, right? So you can come there and you can start examining patients and seeing patients on given days. I have opened several Premier Pediatric clinics appointments. Right, so you can just come. You can prior book a time slot and get a consultant for your training, and then you can start to see which are there in textbooks in real. Right, so few things that we do are exposure to A to Z childhood clinical conditions. Right, A to Z childhood clinical conditions, and then expert consultation. Who are these experts? All are none other than consultants, right? All are none other than consultants. There will be clinical coaching, right? There will be clinical coaching done by consultants. So you will get the taste of Sri Lankan diseases, childhood diseases at your very early ages of medical school. You may be a first-year student, second-year student, third-year student, whatever it is, right? So you will start to see. So we have started them already, right? We have started them already. I don't know whether you can identify these. These are some of your colleagues, right? So this is how we started. You can see children, they have come from all the corners of the country, and I have like carefully selected this patient is going to come. This patient is going to come for exam. Such kind of patients are there. So students can come and start examining children. Once they examine, okay, and these, right, like once they examine, these are the external consultants. So students can present and get their presentation skills sharp. I have seen amount of struggle that students make to present even a single sentence in front of a consultant if you have not trained. Some of these students are first years. Some of these students have not even gone to university yet. They have just passed A-levels and started registering to Premier and started their clinical journey, right? I'm sure some of these are much better than even final year students who have not got this exposure yet, right? So they know murmurs, right? They have seen most of these conditions, right? And then we have international faculty where students get the chance to present and get advices from consultants abroad, right? So this is one of the students who present a case to a consultant from Australia. So he is presenting, and when he presents, you can see Sudhira is assisting. So whatever the comments given by these consultants will be written by our Sudhira or any other pre-intern, and then the record book will be marked, and the constructive criticism will be given to the students, or students will get the benefit of that. Right? So that is what is happening at Premier Mount Lavinia, right? So because I'm telling this, some of the students are telling us, we are just wasting time. We don't have a chance to go to this hospital, that hospital. We don't get permission. So what? And we did not know this. It's like you are ordering something, cake or something from the US without knowing that it is available in Sri Lanka. Okay? So it's all available. It's all there, right? So if you are keen, most of the by now, more than 500, 600 students have already come and got their experience achieved. I'm just telling that this is available, right? And this is the theory program that we will be starting on Monday, right? It's important to know theory before coming to these clinical sessions. That's the general generally it's better. So we will start theory on Monday, right? Monday is 25th, right? So the stage 1 will have most important topics in pediatrics like what? Acute pediatrics, acute care handling, emergency handling. So there will be 2 classes, and GIT, gastrointestinal diseases, and then rheumatology and connective tissue diseases, hematology, thalassemia, leukemia, you name, blood problems, and genetic syndromes, all those, and then dermatology, skin conditions, all those will be done within a matter of 8 days, right? Within a matter of 8 days. If you have not got registered, I will send the registration links. You can register, right? The other questions that students are asking is, now what happens? I register, I'm a first year student, but if I forget, by the time I go to final year, what will happen? Then what happens is you can come to these classes again, right? As you have already registered, you don't have to pay again, right? You don't have to pay again. So I don't know whether you can see, once you make payments and get registered for courses, any of these topics in the future will get free access, right? So that is how things happen. The old school way of doing ERPM was doing all the subjects and graduate and then coming and start studying for ERPM. That is not the common way how we should do. That way will prolong your journey of becoming a doctor by 2 to 3 years, right? So now most of the students have already finished these programs, right? Already finished theory, already finished these programs as first year, second years. Right? So you can join theory, and then Viva, right? Viva, that is where we do all these clinical exposure sessions that you saw with international and local examiners. I remember my Viva programs are not just something talking in front of a camera. It's a dynamic event where people are interacting, external consultants are coming, patients are coming. It's a dynamic experience. Either you can come to Premier live or you can join online, whatever it is, and then you will get the opportunity to see all these patients. We have already done Viva two classes. Saturday is the 3rd class, but you can join from Saturday. First 2 classes will be repeated anyway, right? First 2 classes will be repeated anyway. So that is how it happens. And then procedures will be demonstrated there at Premier, how to take different samples and all. And then you get a chance to come to hospital. You will see those procedures as well. I have introduced the procedure logbook for students who are coming to hospital. So they will get the signature from doctors. Okay, I have seen how to take a blood culture. I have seen how to put a catheter. I have seen how to nebulize a child. I have seen how to give furosemide. All those. So that's the kind of clinical exposure that we get. Just sitting in front of a computer in a closed room and learning medicine is no more. So we have gone several steps beyond that. So get that experience and pass this exam in one go, right? So that's about this. I will send this information if you, for those students who want that, right? Anyway, if we go back to investigate, yeah. So this is Premier, right? When you come along Gold Road at Mount Lavinia, you will see this board. This is Premier. This is Premier Healthcare, right? So this is where I do all these sessions, right? So investigations, what we do, ECG, chest X-ray and echo, right? ECG, chest X-ray and echo, right? We are not going to have a detailed discussion of ECG. Your medicine teachers will do, because for medicine, ECG is a big topic, but pediatrics will have to know some selective things related to ECG. Now, before talking about abnormal ECGs, we'll look at this. This is the normal advanced level type ECG. So you can see P wave, and this is Q, this is R, and this is S, and this is P, right? Vilki, Anisha, Huda, did you see this? Can you see the picture? Yes. So P, and this downward one is Q, and the upward one is R, and this is S, and this bump is T. You know that, right? That's enough to learn. That's enough for us to understand few things. Now, what is this? What do you see here? ECG has got several leads, right? If you talk about chest leads, there are something called chest leads. Right? There are 6 chest leads, V1, V2, V3, V4, V5, V6. Right? If you look at this ECG, right? If you look at this ECG, you can see in V1, what is very deep? What is this one? What is this Kuda? This is V2, this is S. This S wave is very deep. S wave is very deep. How many squares? 1, 2, 3, 4, right? 1, 2, 3, 4. 1, 2, 3, 4. If you take 1 square, how many small squares are there in this one? There are 5, right? In this big square, there are 5 small squares. So here, how many small squares are there in that case? So 5, 10, 15, 20. Am I correct? 5, 10, 15, 20. What is that, Buddha? So that is deep R wave. Sorry, deep S wave. And then if you go to this one, right? V5, you can see what? Tall R waves. How tall is this? 1, 2, 3, 4, 5, 6, almost 7. Almost 7. So 7 into 5 is what? 35. 7 into 5 is 35. So here you have 35. Here you had 20. Am I correct? Yes. Sasandi, am I correct? Yes. There are 4 here. 4 is 20. 7 here. 7 is 35. If you put them together, 35 plus 20 is 55. Right? So if you put this styles R wave and S wave together, how tall is that? 55. 55. Right? If the total of S wave and R wave is more than 35, so this is 55. Well above 35, that is called what? Heart failure. Sorry, cardiomegaly. Cardiomegaly. Cardiomegaly is what? Big heart. Big heart. Right? Heart is big. Right? If you want to know whether your heart is bigger than normal, right? Bigger than normal. One of the simplest tests that we can do is get a ECG done. Get a ECG done and calculate the number of small squares. If the number is more than 35, when you add V2 and V5, that is called cardiomegaly, right? So you will get cardiomegaly, right? You will get cardiomegaly in various heart problems, right? Most of the children with heart failure will have cardiomegaly, right? Will have cardiomegaly. So if you are working in a base hospital, now remember, this is how examiners would ask questions. You are working in a base hospital. What investigation will you do to find out whether the child is in heart failure? Yes. So what do? You would do an ECG, right? Don't say echo, because most of the base hospitals will not have echo facilities. What you do is ECG. ECG will show V2 and V3, sorry, V2 and V5. Remember that as this is, right? V2, V5, R wave plus S wave total, if it is more than 35 millimeters, so that is cardiomegaly, right? Right. So, and when we do theory, cardiology, we will discuss these in and outs, physiology, pathophysiology. I'm just giving an understanding, right? And what is this? What is this? Now here, now compared to normal, can you see that? This is normal ECG, right? QRS, right? QRS. So this is normal. Now compared to that, what is this? Can you see something like 2 R's? R, right? Rabbit ear. Can you see R? If you see 2 R waves in particular leads that we will learn when we do theory anyway in detail. So suppose in V1, if you see something called RSR pattern, R, S again R. If you see that pattern, that is called right bundle branch block. Right bundle branch block. Right bundle branch block. what is this? This is nothing medicine. This is A-level. You can remember there is something called cardiac conduction system. SA node, AV node, bundle of His, Purkinje fibers. Now this bundle of His has got two branches, left branch and right branch. Can you remember? Now there are some cardiac conditions where the right bundle will block. Right bundle will no longer send impulses, signals. So right bundle branch block. One of the commonest conditions where you will get right bundle branch block is ASD, atrial septal defect, atrial septal defect. When you see an ECG in a child with a heart disease, and if you see something like this in the ECG, you know that child has got an ASD, atrial septal defect. In ASD, you will get right bundle branch block. How do you identify? Look at V1. If you see something like rabbit ears, RSR pattern, that's it. Right? That's it. So RSR pattern occurs in this. Right? So you might read different ECG books, ECG lectures. But for pediatrics, if I am to filter everything unnecessary out and put necessary things in, I would put these 3 slides because others are not needed, right? Others are not asked in pediatrics. Remember, I am a pediatrician, so I know what to know, what not to know for a medical student. This is what is asked, right? So right bundle branch block occurs in ASD, right? And then you have something called axis deviation. Now the heart, you know, heart is this, right? Heart is like this. So if I'm to show you this one, right? Let me take a new page, right? New page, don't save, right? So this is the heart, right? So signals would go this way, right? There is an axis for signal pathway. So this is called cardiac axis. This is called cardiac axis, right? There are some conditions where this axis would deviate, right? Axis would deviate. Sometimes axis would go this way, right? Axis would go this way, right? Left axis deviation, or axis would go this way, right? Right axis deviation. So different axis deviations could occur in heart diseases. In pediatrics, we have to know how to detect left axis deviation and right axis deviation. Left axis deviation and right axis deviation. How do you find out whether the axis is normal or axis is deviated? Just by eyeballing the ECG strip. Look at this, Buddha. This is very simple, right? So this is very simple. All right. So what is this? Now, if you look at this one, right? Now these are ECG leads. Several leads are there, right? We can remember 6 leads, V1, V2, V3, V4, V5, V6. And there's another type of lead. Those are called limb leads. Forget about everything else, but look at lead 1, lead 2, and lead 3. Lead 1, lead 2, and lead 3. Right. Now, when you look at lead 1, the blue color one, right? Now, this ECG pattern is voltage is more towards upwards or downwards. Upwards or downwards. Yes. You mean, is it up or down, Buddha? You mean Pramodya? Right? Lead 1, up or down? It's down, isn't it? Right? Down tane the valley. Right. And then if you look at lead 3 is upward, isn't it? Lead 3 is upwards. Am I correct? Right? Forget about lead 2. Lead 3 is upwards. Lead 1 is downwards. Right? Did you see that? I want everybody to see that. Yes. Yes. So everybody must have seen that. Lead 1 downwards. Lead 3 upwards. So lead 1 is coming down like this. Lead 3 is going up. Right. So what is happening? They are trying to reach, isn't it? Reach. Someone is coming down. other one is coming up. One fine day, they are going to meet. What is that? Reaching pattern. This is called reaching pattern. Reaching. So reaching pattern occurs in right axis deviation, right axis deviation. Reaching right axis are accurate, right? Reaching, right? If they are reaching together, that's right axis deviation. If you see this ECG, you know that axis is deviated to right side. Axis is deviated to right side, right? Right side. Kalana Buddha, did you understand that? Kalana Silva? Yes, yes. So if it is reaching, right? If it is, Nilakshi, did you understand? Yes, yeah. So if the pattern is reaching, that is right axis deviation, which means axis is coming towards right side. Why is that? Why is that? Has heart gone mad? No, right axis deviation occurs when the right side of the heart is getting enlarged. That is called right ventricular hypertrophy, right? Right ventricular hypertrophy. This occurs in right ventricular hypertrophy. Right ventricle is getting bigger due to different reasons. If you get right ventricular enlargement, you know that child has got, sorry, if you get right axis deviation, you know that his right ventricle has got enlarged, right ventricle has got enlarged. So remember, just to understand that right ventricle has got enlarged, you don't even have to look at the heart. You don't even have to do an echo. Just by doing an ECG, you know whether the right ventricle is enlarged or not, right? Right ventricle is enlarged or not. All right. How do you know whether there is left axis deviation? Left axis deviation. This is what? This is right axis deviation, right? So what is the pattern? In right axis deviation, you get this called reaching pattern. Reaching pattern. Reaching pattern. Right? Who reach together? It's V1 and V3. V1 and V3 would reach together. Right? V1 and V3 would reach together. Again, right? So it's like this, right? So in right axis deviation, this one, right? There is reaching pattern. What happens in reaching? One will come down, other one will come up, isn't it? So that is reaching. They are going to reach. Then in left axis deviation, what happens? Left axis deviation, what happens is V1 and V3 would leave apart. V1 and V3 will leave, lead 1 and lead 3 would leave apart. So lead 1 will go this direction. Lead 3 would go this direction. They are leaving, isn't it? They are leaving. They are never going to meet. This is called leaving pattern, right? Left axis deviation, leaving pattern. Right axis deviation, reaching pattern, right? Reaching and leaving. Where do you look at? Lead 1 and lead 3. Lead 1 and lead 3, right? Here again, mark lead 1 and lead 3. Right? Okay. Right. So these are simple ways. Right, so this is how we remember. There are complicated ways how to find out the axis, what is the angle. It's up to you to complicate the life. Get your life complicated. Right? McDonald's is telling, I will deliver food, stay at home. Right? So that's up to us to decide which way to take. But this is the simple way of understanding ECG. Right? So leaving pattern, right? Leaving pattern is for left axis deviation. Reaching pattern is for right axis deviation. We can remember right axis deviation occurs in right ventricular hypertrophy, like that. Left axis deviation occurs in which condition, Buddha? Left axis deviation occurs in left ventricular hypertrophy. This is not nothing. This is not rocket science, right? This is not rocket science, so it's very easy, right? So right axis deviation in this thing. And this, if you talk about left axis deviation, so there you get leaving pattern that occurs in left ventricular hypertrophy. Can you remember one condition where you might get left ventricular hypertrophy? There you get left ventricular hypertrophy. Left ventricle is getting bigger. In which condition? Left ventricle would get enlarged when you have heart failure, heart is failing. So the left ventricle will have to struggle a lot. So heart will get bigger, right? Heart will get bigger. Muthuni, did you understand Buddha? Yes, right? So did you understand this left ventricular hypertrophy occurs in heart failure? Right? When you get heart failure, right? When you get heart failure, left ventricle will hypertrophy. How do you know that? In ECG, it will show left axis deviation. How do you know left axis deviation? Look at ECG lead 1 and lead 3. It is labeled lead 1 and lead 3. See if they are leaving apart. If they are leaving, that is left axis deviation. That is due to left ventricular hypertrophy. That is due to heart failure. How simple this is. How simple this is. So this is the amount of knowledge that we have to have in relation in terms of ECG understanding for cardiology. There are a few more other ECGs that we have to know that we will learn when we do theory at relevant topics. Right. Now suppose you have done ECG. Now you know that, okay, the heart is enlarged. Right, heart is enlarged. Oh, the left ventricle is enlarged or right ventricle is enlarged. What is the other way to confirm your doubt? By doing an investigation in a base hospital. Yeah, if you are in a base hospital, we don't have much of luxuries, right? Muhammad Naushad, did you understand? Yes, so Muhammad, if you are in a base hospital, you would do ECG. But the next thing, you would do a chest X-ray. Can you see this one? Now look at this, right? So what is this? So can you see this one? So here you can see a chest X-ray. This is the normal chest X-ray, Lahiru. Right? Lahiru. So this is normal chest X-ray, right? So this is normal chest X-ray. Now compared to that, can you see the other X-ray? The heart is big. Heart is almost filling the whole chest, isn't it? So this is called what? Cardiomegaly, right? Cardiomegaly can be detected by doing a chest X-ray. So chest X-ray will tell us that it's a cardiomegaly assay. Was that understood, right? If you see something like the second X-ray, you would say, okay, this child has got cardiomegaly. Now, sometimes we might see funny shaped hearts on chest X-ray, right? So now look at this, right? So what is this? Now this heart looks like a boot. This is called a boot-shaped heart that occurs in a condition called tetralogy of Fallot. So in this condition, child will present with cyanosis. Tetralogy of Fallot. We learn those in pediatric cardiology when we do theory. So cyanosis, it's a beautiful field, right? So pediatric cardiology is considered as one of the most difficult things to understand. But now you must have understood how simple this is. Right? How simple this is. It's so easy. Much easier than any other A-level or O-level subject, right? So tetralogy of Fallot, child will have something called a boot-shaped heart. Now, if you look at this heart, yes, so what does it resemble? Yes, Charita Balasurya. Charita, are you there? Okay, I hardly can see you. You have very right under right? Anyway, so what is the shape of this heart? This is called figure of 8 appearance, right? This heart looks like figure of 8. This occurs in a particular cardiac condition called total anomalous pulmonary venous drainage, right? Don't panic about this name. It's a big name, but when you start to learn cardiology, you will understand this is very simple. But forget about this condition. At least understand today that some of the heart diseases can be predicted by doing a chest X-ray. Right, by doing a chest X-ray. What are the three things that we learned when it comes to chest X-ray and heart problems? Chest X-ray and heart problems. There are some conditions where the heart will be very big. Heart is big. That is called what? Cardiomegaly, right? So that is cardiomegaly, right? Cardiomegaly. So this is cardiomegaly. Cardiomegaly. Cardiomegaly, we can remember when you do ECG, there will be this R wave and T wave total more than 35. So that is one way of diagnosing cardiomegaly, and then by doing a chest X-ray. Now remember, we have not even touched an echo. Echo එකක් ගැන දැක්කවත් නැහැ, right? Still, we are coming to a reasonable good diagnosis by doing available facilities at the base hospital, chest X-ray and ECG, right? Chest X-ray and ECG. So cardiomegaly will be seen in case of heart failure, and then boot-shaped heart will be seen in case of tetralogy of Fallot, and in total anomalous pulmonary venous drainage, this appearance is called figure of 8 appearance. This is called what? Figure of 8 appearance. Figure of 8 appearance. So figure of 8 appearance. Right. All those. Right. So those are few simple investigations and their results. As a house officer, we have to know this, right? So these are very simple, but as long as you understand this, it will be more than enough, right? And then how to manage heart disease? We know initial management, we know, right? Initial management, we know. Can we remember? Prop up the child, give oxygen, restrict fluids, furosemide, right? Furosemide. Then we can remember the rest of the conditions can be managed according to the underlying problem, right? So depending on the problem, right, the management would differ, right? Depending on the problem, management would differ. So what is this? What is this? You can see the first one is a normal heart. Second one, there is a hole here, right? There is a hole here, right? Lahiru, can you see? Yes. Lahiru Pradeep, right? So there is a hole here. So what is this hole? This is a hole in ventricular septum. This is called what? This is a VSD. VSD, hole in the heart. How do you manage these children, right? VSD, how do you manage? We will write the management. Very small VSDs will close naturally. Will close naturally, right? Very small VSDs will close naturally. Right. Haru, Fernando, Puta, did you understand that? Yes, very small VSDs will close naturally. But if the VSD is large, what can we do? We'll have to do a surgery. You can see that this nice little child has undergone a surgery right at the middle of the chest. She has got a scar, right? This is a VSD closure surgical scar, right? VSD closure surgical scar. So how do you manage VSD? Basically, small VSDs can be closed naturally. The others will need surgery, right? Others will need surgery. And so that's one of the congenital heart diseases and its management. Congenital heart diseases and its management. Now, if you look at this one, right? If you look at this one, this is an acquired heart disease. What is the name here? What is the name? This is infective endocarditis. What you see here are vegetations. Right? These are vegetations. Right? Vegetations. These are post-mortem findings, right? Post-mortem findings. So these are dead body findings, right? So these are vegetations. So if you see a child with infective endocarditis where you have, Puta, can you remember what are the features of infective endocarditis? We were talking about 5-6 features. They will have fever, a murmur, rot spots, Janeway lesions, Osler nodes, and then splinter hemorrhages and clubbing. Can you remember? So that is it. So the underlying problem for infective endocarditis is what they have. That's due to an infection, right? That's due to bacteria, right? So when you learn microbiology, you will learn all these bacteria, but if I am to give the commonest bacterium, this is called Viridans streptococci. Viridans streptococci. Streptococci. Right. Where do they live? They live in the mouth, right? They live in our oral cavity, and when they get a chance, they will go into the heart, right? They will go into the heart, right? So oral cavity, and they will go into the heart. So how do you manage them, right? How would you manage infective endocarditis? The management of infective endocarditis, they will need antibiotics, right? They will need antibiotics. One of the antibiotics that we give is called gentamicin. This is a gentamicin vial, right? And then what is this? This is ampicillin. Why you use gentamicin? Why you use ampicillin? We will learn those in theory, right? It's not the scope of today's session, right? So up to now, what we learned, right? So we learned how a child with heart disease would present, asymptomatic, and some of them will be symptomatic. Right? If you can remember this, it's more than enough. And then what are the symptomatic features of symptomatic children? They might present with fever, they might present with a murmur, they might present with cyanosis, central or peripheral, they might be edematous, right? They might have failure to thrive or difficulty in gaining weight. And then when you examine further, they might have some other features like crepitations, chara-chara sounds in the lungs, and they will be breathless. They will be breathless. And then we can remember they can have acquired heart problems like infective endocarditis. They will have fever, Osler's knots, Roth spots, Janeway lesions, that part. What is the other acquired heart disease? It is rheumatic fever. In rheumatic fever, they will have what? Erythema Marginatum, subcutaneous nodules, chorea, right? Chorea, arthritis, and carditis. And then we can remember this Japanese disease, Kawasaki. They will present with strawberry tongue, red mouth, red lips, and then red eyes and peeling off of the skin. When you know those, you would start to manage the child acutely by giving oxygen, restricting fluids, and then propping the child up, and then giving furosemide like diuretics. After that is done, we'll have to check if the child is having any underlying problem. We do two investigations, simple investigations in base hospital level, Ecg. Ecg, if you see cardiomegaly, that is where you see deep R waves, deep S waves and tall R waves. If the height, the total height is more than 35 millimeters, that's cardiomegaly. And then you can have bundle branch blocks. Right bundle branch block, you see RSR pattern. And then you might have axis deviation, left axis deviation, leaving pattern, right axis deviation, reaching pattern. Left axis deviation occurs in left ventricular hypertrophy, like in heart failure. Right ventricular hypertrophy will cause right axis deviation. Right? And then we know there are different kinds of chest X-ray appearance. The commonest one is big heart cardiomegaly. And then you might have boot-shaped heart that occurs in tetralogy fallow, and then figure of 8 appearance occurs in total anomalous pulmonary venous drainage. And we understood few principles of management of heart conditions. VSD can be managed without doing anything. If the VSD is very small, that will be naturally closed. If the VSD is very big, that will need open heart surgery. Right? That will need open heart surgery. And if it is infective endocarditis, that will need antibiotics like ampicillin and gentamicin. Right. So I thought of continuing the session for 2 hours, but we were able to finish early because you were so interactive and enthusiastic. So thank you very much for joining today. We'll meet again soon. Good night.